So we're going to hear for the next 90 minutes from an extraordinary group of committed scientists and advocates in the area of infectious diseases to get some forward-thinking comments about the world of infectious diseases. I'm Peter Hotez. I'm the president of the Sabin Vaccine Institute, and I'm also the dean of the National School of Tropical Medicine at Baylor College of Medicine in Houston, Texas. And we're joined by these amazing individuals. We have Professor Christian Brechot, who's the president of the Institut Pasteur in Paris. Professor Stefan Kauschmann, who's director of the Max Planck Institute for Infection Biology here in Berlin, in Germany. We have the Honorable Suresh Kumar, who's head of government relations at Sanofi. Joy Fumafi, who's the executive director in Tanzania for the African Leaders Malaria Alliance, ALMA. And finally, Professor Ralph Zinkernagel, who is the professor emeritus of experimental immunology at the University Hospital in Zurich and the winner of the Nobel Prize in Medicine or Physiology in 1996. So really, you couldn't ask, I think, for a better group. Let me begin by making a few introductory remarks before I ask Professor Brechot to make comments. I think over the last 15 years, under the auspices of the Millennium Development Goals, we've seen some extraordinary things happen in the world of infectious diseases. Ordinarily, I'm not a huge fan of United Nations documents. I think a lot of them are forgotten about as quickly as they're drafted, but this one has made an impact because, particularly for Millennium Development Goal number 4 and number 6, we've seen a lot of overseas development assistance that's really made a difference. So for Millennium Development Goal number 4, to reduce child mortality, we've seen the creation of the Gavi Alliance, the Global Alliance for Vaccines and Immunization, and we've just recently got the results in for the last 15 years of Gavi activities. And this is being done through another initiative I'm linked with, which is the Global Burden of Disease Study based in Seattle. And there at the Institute for Health Metrics, it looks like we're looking at between a 60 to 90% reduction in mortality from diphtheria, pertussis, tetanus, measles, a huge impact on polio. Clearly, this has been an incredible victory through expanded use of vaccines. But at the same time, we've also seen now, through the introduction of pneumococcal vaccine, rotavirus vaccine, similarly big gains, a 36% reduction in pneumococcal deaths and 63% reduction in deaths from rotavirus. Also for Millennium Development Goal number 6, to combat AIDS, malaria, and other diseases, we've seen now big gains through PEPFAR and the Global Fund for putting individuals on antiretroviral drugs, 19 million lives saved from HIV/AIDS. Similarly, a 30% reduction in malaria cases and malaria deaths. Not the same dramatic gains that we've seen through Gavi and reducing child mortality because we don't have vaccines, but substantial gains nonetheless. We've also seen now important reductions through mass drug administration in selected neglected tropical diseases, a 30 to 40% reduction in lymphatic filariasis, river blindness, trachoma, and ascariasis. Not the same gains in hookworm and schistosomiasis, but we're still seeing very important global impacts from these new vaccines and expanded use of mass drug administration. By all means, a resounding success. And that's where we've been the last 15 years. But what I want to briefly touch on is where we're headed, because I think, unfortunately, what we're seeing, from my perspective, is a case of what I call global health whack-a-mole. I don't know if you know that childhood game where you go to the circus and you knock down the two guys with your mallet and then the next guy rises up. And this is what's happened, I think, with infectious diseases, because we've now, even despite the gains in childhood mortality, despite the gains in AIDS, malaria, and neglected tropical diseases, we've seen a rise in new forces that are promoting the expanded emergence of a number of other infectious diseases, especially zoonotic and vector-borne diseases. And a lot of the forces I ascribe to what some are calling the Anthropocene. The Anthropocene is, according to some, the newest geological epoch, that as we've finished the Pliocene, the Pleistocene, now the Holocene, at the end of the Ice Age, humankind has so profoundly influenced the environment that we've bought ourselves a whole new set of issues related to climate change, urbanization, new poverty, human conflict. All of these factors have now created this expanded portfolio of infectious diseases. So I want to just briefly, before I turn it over to Professor Brachot, mention a couple of those important forces. One is the changing face of poverty. One of the things that we've seen, in part because of all that massive overseas development assistance, is a rise of a new type of poverty. What we're now seeing is that most of the world's poverty-related neglected diseases are now, paradoxically, in the wealthiest economies, in the G20 countries. The group of 20 countries, the 20 wealthiest economies, and also adding Nigeria, because Nigeria has an economy that's wealthier than the bottom three, now account for most of the world's worm infections, tuberculosis, lymphatic filariasis, dengue, leishmaniasis, Chagas disease, the list can go on and on. So that's somewhat paradoxical but very important. So it's the G20 countries that now are accounting for the world's neglected diseases. So an example is Brazil. Brazil is the wealthiest economy in Latin America. It's a G20 economy. In northeastern Brazil is the home of Latin America's most of its severe neglected tropical diseases. Northeastern Brazil, you're seeing schistosomiasis, leishmaniasis, Chagas disease, this is where it's concentrated, and this is, of course, where Zika, where the large number of cases of microcephaly. So it's the concentrated pockets of poverty in the G20 countries that now, as we move into the Sustainable Development Goals, are accounting for where we have these diseases. And my new book just came out last month describing this phenomena that we call blue marble health, that the whole idea of developing versus developed has morphed. We're seeing a general rise in the global economy, but it's leaving behind a bottom segment of society. The same is true now in the United States. In the poor parts of the United States, particularly in the South, particularly in Texas, where we're based, we now estimate 12 million Americans live with a neglected tropical disease led by Chagas disease and toxocariasis, cysticercosis, and others. So again, the poor living among the wealthy. Another very important force, in addition to poverty, is, and probably the next most important, is war and conflict. Ebola rose out of West Africa because of the collapse of the health system's infrastructure due to decades of atrocities in Guinea, Liberia, and Sierra Leone. And now we're seeing the same set of forces happening in the ISIS-occupied areas of the Middle East, of Syria and Iraq, where we've now seen the reemergence of polio and measles, huge increase, uptick in the number of cases of cutaneous leishmaniasis. In Syria and Iraq, more than 100,000 cases of leishmaniasis. Animals are being trafficked all over the Middle East and North Africa with the collapse of borders. So we're seeing brucellosis, MERS coronavirus. So this has now become one of the next big hot zones of infectious diseases, is the Middle East and North Africa. And in parallel with that, we've seen now the rise of disease in southern Europe. So over the last 5 to 6 years, we've seen the entry of dengue into Portugal, chikungunya, West Nile virus in South France, Italy, and Spain. We've got schistosomiasis now on the island of Corsica, and according to some, the reemergence of malaria in Greece. And what's the basis of it? Well, again, we don't really have a mechanism for sorting this out. Is it human migrations coming from the conflict zones in the Middle East, coming across the Mediterranean? Or is it climate change? Because if you talk to the experts in climate change, they'll tell you that next to the Arctic, Southern Europe is the next shoe to fall. Or is it the economic downturns there? The point being that I think one of the future directions when we think about infectious diseases is we have to look beyond the biomedical model, and we have to think about getting out of our comfort zone and not only talking to other microbiologists and infectious disease experts. We have to talk to the economists to understand the role of poverty, political scientists to understand the role of conflict. We need to be able to talk to the geologists and the earth scientists to look at the impact of climate change, the sociologists to understand the impact of urbanization and human migrations. And that's not easy for us to do because in the academic world, we're quite siloed. There's not a lot of incentive for us to do cross-bridging. So I think these are the next big wave of vector-borne zoonotic diseases that we're going to be seeing from these modern 21st century, what I call Anthropocene forces, the poverty, climate change, all of the other things that some of us link to planetary health. Finally, I think we still need a mechanism to develop interventions for a lot of these diseases. We still have a generation of vaccines that we can make for many of the most deadly infectious diseases, but also the not so deadly. We also have to look at some of the chronic and debilitating infections like Chagas disease and leishmaniasis, and the opportunity that we have to make vaccines and other interventions for these, because they continue to mount in association with the new poverty, the new conflict, the climate change, the urbanization. We're going to need a whole new generation of interventions for that. I know Professor Zinkernagel is going to be talking about the prospects for making some vaccines for some of these chronic diseases, and I hope that'll make a vigorous discussion. So the good news is over 15 years of the Millennium Development Goals, tremendous progress in childhood preventable diseases through vaccination, through AIDS, malaria, and neglected tropical diseases. But we've now got a new set of forces, and that's why we're seeing problems like Ebola and Zika, leishmaniasis, schistosomiasis, and other vector-borne diseases. And so I hope we have a good discussion today to really sort that out. Thank you so much. I'm going to turn it over now to Professor Christian Brachot, who is the president of the Institut Pasteur, and under his leadership, Pasteur has accomplished enormous gains in global health, not only in Paris, but at the affiliated international institutes. And we're going to hear his perspective now, titled From Ebola to Zika, Areas of Action to Limit the Impact of Future Infectious Diseases Outbreaks.
Thank you very much, Peter Ortez. So exactly as has been very nicely presented, we have to build on success. And I like very much in your presentation, Professor Ortez, the fact that you have emphasized that we are building on success. But I'm not going to reiterate what you have elegantly presented. We are also facing huge challenges. And in a context where the human is completely changing his ecosystem with the deforestation, urbanization, with obviously the climate change and the overall environment. So clearly we are facing the question of global health and One Health. So to follow up on the first presentation, I believe I would like to emphasize the following points. Clearly we need financial investment, overall financial investment. We need coordination, which is very easy to tell and actually very difficult to achieve. And we also need to convey to the field, to convey to the countries with low income or middle income, the progress of science, of medicine, and of public health. So it's not only about investment. It's not only about engaging a number of stakeholders. It's really, again, about translating to concrete actions what is being decided. It's also about basic research. One of the big mistakes we might but we will not, but that we might encourage would be to focus too much on the applied research and on the huge problem of translation to the field. We really need to have this, we need to create knowledge, very interdisciplinary as it has been presented, and then again to convey. So the first point I want to take is really preparedness. preparedness and coordination. When you look at the Ebola epidemics, it has been very striking. I'm the president of the Institut Pasteur. The Institut Pasteur is a very famous research institute in the very center of Paris, 2,500 people, very basic, very interdisciplinary. But as it has been mentioned, we are also talking about a network of 33 institutes in 26 countries. 10 in Africa, 9 in Asia, 3 in South America, and all over the world. And the way we have been working with Ebola has been first to meet with the urgency. Our teams were among the first to come in particular to Guinea. But then, and at that time, obviously in coordination with WHO and with NGOs, we were somehow isolated. And then many institutions came. But then the question was really the coordination. And maybe too many institutions were there and not enough coordinated. So it's not only about goodwill and investment, it's how to organize and how to be more efficient. And now we have the example of Zika in South America and also Caribbean area. And although not exactly in the same context, we again face this. So we need to reinforce infrastructures, on-site capacities. And the network of the Institut Pasteur is one of the several institutions which can contribute, obviously not by itself, but in partnerships. We need to have the trust of the local government and the population. The Institut Pasteur network has been established 125 years ago. We are there for long-term actions. And the Pasteur Institute in each of the countries combine public health, research, education. And this is really key. So my first point is really to emphasize that when we think of how to translate these efforts, we must help the local governments, but also at a more, say, regional and global level, we must help building the infrastructures, and not only the health infrastructures, but also the research infrastructures and the infrastructures for education. Regarding the coordination and the preparedness, there is an interesting initiative, and the Institut Pasteur is part of it. It's called the Coalition for Epidemic Preparedness Innovation. And it's really about preparing for the preparation for the production of vaccines. Professor Otters has mentioned Gavi, which has been a fantastic initiative with a lot of excellent input. We have also the DNDi initiative for neglected tropical disease. So we have made a lot of progress, and we are making a progress with several initiatives of coordination. Again, the question is how to link this and to build on the trust of the local governments. The second point I want to take is really about the, and I forget something important, it's about diagnostics. Sometimes we forget that one of the major, of the key challenge for handling an epidemic is to reinforce the local capacities in diagnostics in all these countries, and this must be part of the on-site capacities development I have been referring to. The second point I want to take is education and training. This is obvious. Everybody is talking about education and training, and you have a number of meetings on this. But we can do much better. It's about really training, teaching the next generation of medical doctors, but also obviously of scientists, of veterinaries, of pharmacists. And this is a key mandate for all of our organizations. And again, the Institut Pasteur is one of the several institutions which can be helpful, and we are using our network to set up what we call the Pan-African Coalition for Training, where we really want to have a strong input. Briefly, it's also about career tracks. One of the problems is that quite frequently we provide some support to scientists in Africa, in Asia, in South America, and they get an excellent training. And then after a while, they just leave because there is no career track which is being offered. So at the end of the day, this is a waste of money, and this is sometimes a little bit depressing. All of this we must contemplate in a public-private context. I strongly believe that the partnerships with the large pharmaceutical companies is one of the key components which sometimes has been neglected, and not only the international institutions. And finally, sharing information. We have entered the era of digital communication. We have entered the era of artificial intelligence. And however, we hardly take advantage of this to fight against the new epidemics. So we have huge possibilities, but again, they can only be built if we put a lot of investments on-site capacity. What does it mean to have fantastic computer biology-based softwares if we just don't have on-site the IT infrastructure just to handle the data, to generate the data, and then to share the data? So there are unique opportunities which, again, can only be contemplated in a public-private partnerships and with the local governments working with international institutions to really set up a network of infrastructure which will be necessary. And again, the Institut Pasteur is one of the institutions which can contribute. We are building what we call the Pasteur Global Health Omics Centers, where we provide different institutes with the capacity to store samples, to generate the data, and then to share the data. But again, this can only be seen in partnership. So to close, I would like to emphasize that we are in a very contrasted situation. We are building again to a lot of success. We are facing huge challenges. We have fantastic tools to face these challenges. We really need to find the good mechanisms to translate all this progress within the low-income and middle-income countries, and then and only then we can be successful. Thank you very much.
Thank you very much. Next, we're going to hear from Professor Stefan Kaufmann from the Max Planck Institute for Infection Biology, and he's going to talk to us about new culprits and old foes, how to combat both.
Hello, Stefan Kaufmann. Yes, the UN General Assembly had 4 high-level meetings over the last couple of years, and 3 were on communicable diseases, stopping AIDS, HIV, Ebola, and now more recently antimicrobial resistance. I would say infectious diseases indeed, as the speakers by now already have emphasized, are back on the radar screen in politics and in intergovernmental institutions. Apparently it is becoming more obvious to politics that local, regional outbreaks can turn into pandemics, and in simple words, that pathogens do not respect borders. Now, as already mentioned, I'm from the Max Planck Institute for Infection Biology, and there we focus on basic research. However, in my group and team, we have from the beginning on emphasized needs from the society, and therefore we prefer to move from the bed to the bench, or from the bush to the bench, rather than from the bench to the bed and bush, as sometimes occurs. And in that context, we got a TB vaccine that is just entering a phase 3 trial, which is on efficacy. It is a tuberculosis vaccine, as just said. It is licensed to the largest vaccine producer in the world, and that's the Serum Institute of India, if you calculate by doses rather than by income. And the other way we approached this was by creating markers. You already mentioned the diagnostics. We even wanted to get a step further on prognostics and can now prognose who will develop tuberculosis tomorrow. We can say today, and that helps you, of course, to offer preventive therapy, but also to prevent transmission, because it's only the patient who transmits the disease. And that was done with the Gates Foundation, and it needed a lot of trust in the 7 partners on the African continent. More recently, I've been involved in the G7 health issues, which was meeting last year under the leadership of the German government, and now in the G20. And I'm extremely happy and proud that both G7 and G20 have taken over health issues in their agenda. Let's hope now that promises also turn into reality. Unfortunately, sometimes it occurs, fortunately, and sometimes it doesn't occur. So I would like to make actually more or less 4 points, and that I would like to integrate into a more global picture the threat of newly emerging diseases, that's the old foes more or less, into a broader picture that there are also diseases that are with us for centuries and actually kill a lot of people still. Unfortunately, we have seen that sometimes emphasis on a single disease deviates activities and financial resources from the more global picture, that is, from the more global health. I would like to integrate in the whole picture also the antimicrobial resistance. Sometimes I would argue later that a new pathogen may not really a new pathogen in bioscientific language, but maybe a new one. If you have a totally resistant pathogen, it is a new pathogen from a medical and social standpoint, although it may still be the tubercle bacillus by biological standpoint. The third point I would like to briefly make is that yes, biomedical failures need more research, need more engagement in the industrialized world, but we would also well advise to think about human rights as you see them in the Human Rights Charter, and I think that improving the right of human rights is an important factor in addition. Finally, obviously, as will be probably done in the next speeches as well, and has been done already, integrate that into a financial context and more or less convince the politicians. I don't think we need to convince you that whatever we do is still a bargain, because the most expensive approach is dealing with diseases that are there, and it's much more cost efficient to prevent diseases. Yes, Ebola clearly was a humanitarian issue, but of course also is a wake-up call, and that's the good part of it, because it reminds us of the failing health systems in poor countries, and, let me stress that, of the global failures, including the industrialized world. Somehow the people realize that infectious diseases, in scientific language, are logarithmic. They don't calculate it. If you have 5 infections a day, after 10 days, you have about 10 million infections, or if it's a disease, also 10 million diseases. Next day, 1 day later, it's 5 times 10, and that's 50 million, and the next day is 250 million, 11, 12 days, and Europe has been infected on a pure statistical calculation. It has been said by the WHO and by many others, Ebola is a peace and wartime disease, and that's right. Here's the peacetime, and we need to be prepared. We need to be prepared during peacetime for wartime. That's true for many other diseases. Zika is the most recent one. And there are, however, other diseases, which I would like to emphasize in the global picture, which are only wartime. These are neglected diseases. These are diseases in the US language, WHO language, EU language often uses the word poverty-related diseases. And let me take one case which I'm most familiar with, and that's TB, which is still the deadliest disease in the world amongst infectious diseases, obviously, and kills 1.5 million individuals annually. and causes about 10 million cases of disease every year. And that brings us to a second issue. It's no longer just the canonical TB agent or disease. It is also a new disease because we're facing now multi-drug resistant strains. We're facing extensively drug resistant strains and totally resistant strains. And let me emphasize that again. I think, medically speaking, this is a new pathogen because it matters whether you can treat a pathogen if you have access to drugs. But if you even have access to drugs and can't treat a patient, then I think it is a novel issue, clearly. And that perhaps brings us already then to the next part, and that is clearly antimicrobial resistance, which I consider extremely important, and I think, again, is intertwined with all the diseases. It has been estimated that 700,000 individuals per year die of antimicrobial resistance, and we often think that this is something that is mostly interesting and important and threatening in the industrialized world. We think of sepsis, nosocomial infections, but that's only half of the truth. It's correct. The number one killer amongst drug-resistant strains, again, is MDR-TB, killing 190,000 individuals. That's 27%. 27% of all antimicrobial resistant deaths annually. And I think that we should keep in mind that it is a disease of all of us in the world. And again, there is no border that could interfere with that. So both old foes and sooner or later new foes will suffer from antimicrobial resistance, because what I told you about bacteria is also true for viruses sooner or later, and we have seen that already. We have seen that already for HIV/AIDS. So let me come more or less to the end. We all agree, I think, and I don't have to really go into it again. We need an emergency preparedness for those that are going to come, but we also need a better preparedness for those that are already there. Those, I mean, threats. There's a lot of money figures now around. Some talk about a 50 million enterprise annually, because that's what it costs, calculated what it costs us all on average for newly emerging diseases if we calculate everything together. But it's about 3 to 5 to 10-fold higher if you consider not only newly emerging diseases but also the old foes. And I still think it is a bargain because, as I said before, any calculation that is available, it's more expensive. It's more expensive to talk about disease and deal with disease than about talking about and dealing with preparedness and therefore preventive measures. Global availability of functional healthcare systems are enormously important. Probably others are better equipped to talk about this in more detail. Let me focus on two more issues, and then I'll finish in a minute. This is first, again, research and development. Vaccines have been stressed. I would just like to reiterate that vaccines are the most cost-efficient intervention measure in the world of medicine. That's accepted and has been stated by WHO, by UNICEF, and many, so it must be true. It has led to the eradication of at least one disease, smallpox, and will hopefully come to the eradication of a second disease, that's polio. We are almost there, although it's difficult to get the last 1,000 or so. Never, ever has there been a resistance developed against the vaccine, and by biomedical reasons, you can also explain why. So it's rare. I won't say impossible, but it's rare. And in the past hasn't happened. On the contrary, vaccines in the case of pneumococcal diseases have even reduced antimicrobial resistance, because vaccines protect people, and therefore they don't spread, and that ultimately leads to less cases. I would bring two more things. First, culture is important, and we have to educate people in affected areas to do the right way to do it. This has been spoken so much in Europe and the US that I don't want to really dwell on it, but it's clear important that eating bushmeat, which is just like us eating deer, by the way, can cause outbreaks. Contact after burial practice is an important issue, and we should sensitively discuss that. But even more importantly, or less well stressed, I think, is the issue of human rights. It is the right of health. It is the right to have access to the latest successes of research and development, and don't forget of the colonial legacy, mine companies who exploit still people, leading to diseases, segregation, and poverty. I guess I stop here and be happy to discuss that in more detail later on our roundtable. Thank you.
Thank you very much. Thank you. We're going to move to our third speaker now, and this is the Honorable Suresh Kumar, who is coming from Sanofi, and he's going to talk to us about access, innovation, and price as prerequisites to preempt disease, and how all stakeholders must play their parts and make this happen.
Good afternoon. As a former government official and policymaker, and a current industry executive on a panel so distinguished as this, made up of scientists, medical doctors, and need I say, a Nobel Prize winner, I truly am humbled. I thought I'd focus on my experiences and on policy issues that are critical to combat not only the spread of infectious disease, but also to establish global health security. So let me begin with some of the facts. To the audience, visualize as we speak what disease means beyond all the words you've heard. Visualize Africa. Visualize families and communities who've gone through it. That's where we need to begin. Ebola first struck in 1976. That, ladies and gentlemen, is 40 years ago. And it happened in the DRC. 318 reported cases, 280 deaths, with a death ratio of 88%. That very year, 40 years ago, it also struck in southern Sudan. 224 cases, 151 deaths, a rate of 53% death. Since 1976, Ebola has struck several times in geographical proximity to earlier outbreaks, until 2014. And we all know what happened. 28,652 cases were reported on the other side of the African continent that eventually resulted in 11,305 fatalities across Guinea, Sierra Leone, and Liberia. Without doubt, the world dodged a bullet in the last Ebola crisis. It impacted impoverished small countries with weak health systems and infrastructure. Imagine if this had happened in Mumbai or Mexico, megapolises. It almost nearly happened in Lagos, which had better health systems, and the world stood to gain. 40 years after Ebola first struck, policy response and progress has at best been anemic. In these 40 years, we do not as yet have a cure and are barely beginning to have a common understanding and agreement on treatment protocols. Yet, tragic as it was, 11,300 people did not die in vain. The last Ebola scare brought stakeholders together with a sense of purpose. Public institutions provided grants that enrolled the private sector. Regulators moved expediently, assuming reasonable risk to get products to market, and companies and countries, big and small, collaborated, so we now have 3 vaccine candidates to counter the disease. Progress, but not yet safety, but reason to be optimistic. So what have we learned, which is the topic of the discussion today from Ebola, or for that matter, what did we learn from the beginnings of Zika? At the macro level, we now know that infectious disease knows no barriers and crosses international borders with impunity and quicker than policy and scientific responses to the problem. Second, the frequency of infectious disease outbreaks are increasing. Third, rapid urbanization, increasing mobility, migration, deforestation, and climate changes make us all more vulnerable to infectious disease than ever before. Ebola moved from East to West Africa and infected individuals well beyond Africa. Zika moved from Brazil across Latin America to the United States. Most countries and even multilateral institutions are not well prepared to respond to global epidemics caused by emerging pathogens. We realize that the hidden cost of epidemics is much bigger than the medical cost. For example, lost trade, travel, and tourism results in reduced economic well-being. The GDP of the 3 Ebola-affected countries shrank significantly in the following years after that. Strained healthcare systems fighting epidemics leaves vulnerable populations even more vulnerable. After all, there are few healthcare professionals to attend to regular patient needs, for example, pregnancies, malaria-related problems, etc. You also heard the need to sensitively educate populations and influence culture. This is critical because it does compound the problem. For example, burial practices in West Africa, as also the need to use local people to meet their community. And that's why 70% of the dead were actually serviced and helped by the American and international Red Cross societies. We need to better anticipate, and we need to align. Significant changes to our approaches to global public health is required to keep the world safe. And let me give a few examples at the micro level. Scientists, researchers, and medical professionals on this panel and beyond need to agree on common testing and treatment protocols. We need to share more, share quickly, and collaborate better. That is a need and a reality. In dealing with infectious disease, Ebola taught us that we need institutions like the WHO and the CDC to robustly forecast, identify, and target areas of risk. And then, by increasing global public awareness, we need to mobilize funds for developing cures. The UN system needs to work better with greater coherence between donor and recipient countries, where the West cannot dictate to the rest, or where lower developed countries cannot expect donors to write checks and just go away. Agreeing on accountability and outcomes goes hand in hand with budgeting and funding. Rigorous scientific debate is good, but coherent and aligned treatment protocols are a must. Between the MSF, which did a great job in the last crisis, the WHO and the CDC, it is safe to say, was not a common agreed protocol on how to treat Ebola. We need to move on. The need to train epidemiologists who can trace, track, and help contain disease across continents is a must. There is a huge shortage in that area. Funding and financing must be the firm foundation to drive future success. You've heard it's not a choice. Innovation across multiple areas is a necessity. It is not something which can be taken for granted. It is not going to be a trade-off between, it's not a trade-off whether the areas which should get funding are infectious disease, should be chronic disease, or for that matter, should be neglected tropical disease. I think we've reached a situation where we have not understood the foundations on which we have built. We need to address infrastructure needs, we need to address financing needs, and out of that comes several of the other issues which we talked about. Lest there be a feeling that this is just a question of doom and gloom and nothing has changed. I think tremendous progress has been made in areas, I think speakers have already alluded to, well beyond science and well beyond economics. And I would like to really go there and end on a more positive note in terms of what could be and could be done. In the world of technology, healthcare adoption of technology is amongst the lowest of any sectors. The use of technology, the sharing of information, the mining of data, and the ability to use big data is a first stop. Second, not every intervention requires high capital. We can have hospitals, we can have the beginnings of clinics in West Africa with lower capital if we go modular, prefabricated clinics. After all, there is little fun to building structures which we cannot sanitize and having to tear down. These come at a fraction of the cost. Much as those of us who are privileged to have lived in richer countries talk about drones for Amazon deliveries, drones delivering medicine and clinical supplies to affected remote regions in the world is the way to go. In the interventions of developed countries in the Ebola crisis, for 30 days, there were no protocols of helicopters which were deployed, picking up either Ebola-infected patients, tissue samples, or blood samples. So you would argue, what good did helicopters and feet on the ground do if you could not treat, get, identify, or diagnose patients? And yet we have all this new technology which today, biologically, in the biological sciences, in the technological area, are really inspirational in terms of what can be done. I remain cautiously guarded. I have attended many a session like this, and it's a privilege to be with people who know. But I'd like to see some more action, as I was telling people over lunch. Why do I sometimes get the impression that we are always the same speakers, speaking on the same subject with each other at different venues over different lunches and dinners? If we stop there, I think, again, visualize, as I said, visualize what happened in Africa. Now visualize, in a slightly different way, what happened in Brazil, from the jungles of the Amazon to the beaches of Miami in the United States. I can give you any number of statistics to those who want. The number of cases until September 29th are all on the website. When you visualize, you talk of individuals suffering. But Zika is a little more controlled at this point in time because the US has the epidemiologists, has the infrastructure to cope. How do we translate those learnings and take it to different parts of the world? But at the heart of it, ladies and gentlemen, is one question. We all know the need and use of funds. We rarely know where the source of funding is going to come from. And on the last note, I represent two countries, one by birth and one by affiliation and my current nationality. I've had the privilege to serve on the US government cabinet, and I can tell you without a shadow of doubt, spending 18% of our nearly $18 trillion economy on healthcare does not make us right or righteous. But on the other extreme, India is spending less than 1% of its GDP to treat 1.5 billion people does not make it right either. The OECD average of 6% odd is still not enough. And if you agree with me that population health is national security, then you will agree with me that governments have an obligation to fund adequately to take care of the population, as private sector has the obligation to innovate cost effectively. Thank you very much.
Thank you very much. All right, we're going to hear, thank you so much. We're going to hear now from Joy Fumafi, and she is the Executive Secretary for the Africa Leaders Malaria Alliance, and she's going to speak to us about accountability at the community level.
Thank you very much. I don't know if you can all hear me. I'm privileged to be amongst this distinguished panelists. I'm not a medical person. My profession is management, and more specifically financial management. But let us look at where we are. I was a member of the UN high-level panel on the global health crisis that was appointed last year and submitted its report to the Secretary General at the beginning of this year. And so I will not repeat to you the findings that were actually enumerated by panelists here. But I think what is important for us at this moment, as we see what we assess what is required for the SDGs, is to appreciate that there is a lot that needs to be done, but there's also a lot that has been achieved. We have this summit here because we appreciate that in order to deal with any health issue, all global stakeholders need to be engaged. We appreciate that the impact of infectious diseases on social, economic, political stability is so enormous that as we recommended as the high-level panel, you actually need to engage the UN at a much higher level than even the World Health Assembly. The foreign ministers, the finance ministers, the heads of state need to be engaged. This was a strong recommendation that came from the panel. We also recommended a global summit on health crisis that will engage all stakeholders. So starting from that very, very big bird's eye view, what are the implications at country level? You have heard about the non-compliance with the international health regulations. That was a given. That there were weak health management information systems overall in a lot of countries, very weak surveillance. But what we found that was actually driving the spread of the epidemic, even much more than this, is the failure to engage effectively at community level. The failure to use existing community structures, and the failure to build ownership of the solutions at community level. And this failure driven primarily by the fact that the health sector does not use social scientists. Social anthropologists are not traditionally engaged by the health sector. So this is an additional gap that I want to highlight that we have not highlighted here. Now, on the 28th of August this year, at the TICAD meeting in Nairobi, Kenya, WHO launched a report on public financing for health in Africa, from Abuja to the SDGs. That was the title of the report. The report revealed that out of every $100 that is spent, that is allocated to the budget in Africa, $16 per 100 is actually allocated to health and nutrition. And this is more than a lot of us thought. And out of the 16 that is allocated to health and nutrition, only 10 is actually spent. $10 is actually spent. And out of the $10 that is spent, only 4 goes to where it is needed and spent on what is needed. So what are the implications here? The implications are that there is a huge governance, effective management, and accountability deficit. So I would like to speak to this deficit. And I want to speak to it because I believe it is not all doom. on the African continent. I'll give an example of a healthcare worker who in 2005 in the village of Kisongo in Tanzania lost her firstborn child to malaria. Now, this same woman is now has 3 children that were born post 2005. None of them have been lost to malaria. But in the past 5 years, none of them have contracted malaria. She's working at a factory in Arusha, Tanzania, which is Kisongo is actually in Arusha, where they manufacture nets. So she knows the value of this, of protecting her children. But most importantly, the factory hires a lot of people, thousands of Tanzanians, and they're exporting these nets all over the continent. Now, this is the vision that we want the SDGs to reflect, a vision of productivity where resolving health challenges is actually driving growth and development and creating opportunities for people on the continent. Now, how do we get to that stage? We in the African Leaders Malaria Alliance have been working on accountability and trying to use the concept of accountability to actually drive the change in efficient use of resources and in applying the technical tools and being guided by the targets and the frameworks that have been designed by people in the global health community. So what we are advocating at country level is that there should be an accountability tool in each country that is built from community up, that can use any model. Building from the community up, you could start with hearings, community hearings. This is something that civil society groups have been driving. But these hearings must be responding to an assessment or an evaluation of the performance of the health system at country level. And we have been recommending the use of scorecards, which are driven by the Health Management Information System, a strengthened Health Management Information System, and that uses smart indicators that are going to be reviewed by the community, by the service providers, by the political structures at community level and at national level, and by the government and its partners. And that engage in bottleneck analysis from community level right up to national level, and that identifies areas of bottleneck resolution and assigns responsibilities to all stakeholders, including members of the community, including the government, including partners and stakeholders, and monitors the performance of this bottleneck resolution process. So what we are recommending is that we need to build a system from community level upwards that is based on a service delivery framework that is owned by everybody, that can be used to hold every stakeholder accountable for results. And that it is only when we do this that we do stand a chance of achieving what members of the panel here are talking about. Because our current system is actually top-down, and our current system is not able to identify the solutions that can apply at community level. And our current system is not owned by the very people that it seeks to serve. Thank you.
Thank you very much. Our final speaker before we go to the discussion is Professor Ralph Zinkernagel, who's at the University Hospital Zurich, where he's Professor Emeritus of Experimental Immunology. And he's going to talk to us on why our vaccine is efficient against acute lethal, but not against persistent chronic infections, a topic of great personal interest to me as well.
It's a pleasure to be here. Thank you very much. I'd like to talk about some very general issues. First, what have we learned about infectious diseases and prevention or control of infectious diseases with the example of Ebola and Zika? I'd say at the end of the day, not very much. And why do I say that? Because I think humans, in very general terms, we are stupid. We do not even apply the knowledge we know about. And I think the measles epidemics, for example, in Switzerland, a few years back, reflects that very nicely. I mean, how stupid can you be and not vaccinate your kids because you think it contributes to maturity of spirits if you go through a wild-type infection? So, there is a huge discrepancy, I think, in our world today between our individual needs and wishes and the needs of this world. And I've jumped over my first slide. Biologically, humans need 25 years to guarantee the survival of the species, because after 30, you won't have kids in general terms. So, after 25, humans are not necessary any longer to live, because then the next generation is on the earth. And that is the reason why acutely lethal childhood infections are so important, because if young women don't survive these acutely lethal infections, the species goes. And I will try, from that very general term, try to explain why that is so and how this limits not only our wishes but also our capabilities. And the conclusion of all of this is that we need education, education and education, particularly of women. Males usually are useless, but women transfer knowledge into everyday's behavioral needs and are based on efficacy. Now, the alternative to education is unfortunately only dictatorship. Because a dictatorship, be it via church or religious institution or via political dictatorship, can implement reasonable, unfortunately also unreasonable measurements, but it certainly can implement decisions that are hopefully rationally based. And I think the multi-drug resistance of TB is largely a consequence of the breakdown of a political dictatorship that implemented with fear the correct use of the antibiotic. I mean, nothing is perfect. So, let me go through some aspects, general aspects, how we could maybe understand and therefore implement certain measurements. There are two types of infections, and be they viral or bacterial or parasitic, doesn't really matter. In one case, the virus destroys the host cell. And these, of course, we call cytopathic infections, and the result of such an infection is usually in 5 to 7 days you are dead. Polio, smallpox, measles, tetanus, diphtheria belong to that category. But there are many more infections of this type where the infection has no consequence for the physiology of the cell. Of this type are hepatitis B, hepatitis C, HIV, many infections. Now, from the immune response on which is based the whole idea of vaccines, of course, this side is important. Because in this case, you must have an efficient immune response, otherwise you are dead in 5 to 7 days. And what the vaccine basically does, and what the efficient immune system does, is generate antibodies that prevent the lethal cell cytopathic virus to spread via the blood, in particular also to the brain. Most of us only have one brain, and therefore, once it's reached there, you're dead. All these infections are completely different. In fact, it's the immune response that attacks an infected cell that causes the damage, because the non-cytopathic infections, by definition, do not cause a damage. So all these types of infections are actually immunopathologies. It's the immune response that causes a pathology, and the physiological resolution of that conundrum is very simple. These infections usually jump from a virus-carrying mother to the unborn or the newly born, freshly born offspring. And the offspring at that time has no immune response. And because it doesn't have an immune response, this immunopathology does not happen. So an ideal coevolution of these non-damaging viruses transferred from the mother to the offspring, almost an ideal solution. If it comes later, this infection, then you have the damaging effects of the immune response. All these infections, you need early efficient immune responses, and basically the vaccines that work imitate that situation. They basically make you make an antibody response even before you have seen the infection. And that's why these vaccines are wonderful. And that's why we don't basically have vaccines against these types of infections. And a major reason is that these types of infections do not have a constant surface antigen configuration. They simply vary their surface antigens all the time. HIV is an example, plasmodia causing malaria is another example, and so on. So only against constant, genetically constant antigens can you make a vaccine. And secondly, only against acutely lethal viruses or bacteria you can make a vaccine. So what is my conclusion? My general conclusion is it is an absolute illusion to think that we, be it scientists or politicians, can do better than evolution if we use the same tools as evolution uses, namely neutralizing antibodies, for example. There are no neutralizing antibodies against variable surface determinants that cross-protect against all the variants. Otherwise, we wouldn't have the variants. I mean, you know, how stupid can we get? So a general vaccine against all influenza or a general vaccine against all the malaria is simply, you can say, not impossible, but it's very highly unlikely. And I think there we need education, 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 not only of scientists, but particularly of young girls, but also of politicians, because as scientists, we have largely failed to bring solid messages to all these three levels. Now, at the end, I don't think we want to have dictatorships, but fear, also fear of death and fear of disease, is a very good motivator to accept dictatorships, be it religious institutions, be it political or otherwise. And the only way to overcome that is, I say it again, education, education, and education. Thank you.
Thank you, Professor Zinkernagel. I'll take the chairman's prerogative to say that the good news is the stupid genes have left Switzerland. The bad news is they've come to Texas, where I work. We now have Dr. Andrew Wakefield, who's moved to Austin, Texas, where he's helped to ignite a new movement called Texans for Vaccine Choice. We now have 45,000 parents who've opted their kids out of vaccination. And later on this month in PLOS, I have a paper coming out saying the return of measles epidemics is inevitable to Texas, and for all pseudo-scientific reasons about erroneous links between vaccines and autism. And I get involved in this because I have a daughter with autism and I make vaccines for a living, and I just try to show how the two are not related. But we're in for a terrible battle in the state of Texas in the coming weeks and months. It's late. I had some very clever questions that I was going to ask the panelists, but I'm going to cede my clever questions in order to allow audience participation for the next officially 20 minutes, but I'm going to see if we can sneak a few extra minutes in. So I'd like to open it up to the audience. And just before we do that, I want to recognize a very special guest that we have here, Dr. Renming Lee, who's the new Assistant Director General for Infectious Diseases at the World Health Organization. Dr. Ren, do you want to just raise your hand? And we're very honored to have you here. So please, let's take some questions for the audience, and please use the microphone. And don't be shy. Yes, well, we have one. Please come up to the microphone.
My name is Valeska Lindenberg. I'm an immunologist from Düsseldorf. And I have a very detailed question. Being a woman in a G7 country, being well educated, I have a concern about the detail of education, namely that I do not know when to plan a career before I'm 25 years of age. So I would like to ask Professor Zinkernagel whether he has a suggestion how I can secure the quality of my gametes, so the genetic material, how I can reduce the risk I have of accumulating chronic infections that I could pass on to a fetus while having an academic career, and how we can incorporate this type of detail, which is, I think, a health concern, into the education program that we want to enhance. Thank you.
You know, this, of course, is a very important question you raise. And I said initially, you know, humans are basically a very queer, strange species. And in detail, we are rather dumb and stupid. And why do I say that? Once you know that HIV is transmitted by sex, and you don't obey safe sex rules, you are stupid. I mean, you know, life is basically very simple. And the same is true for Zika virus at the moment. We know very little about Zika. We don't know when the mother gets infected, how long she is infected, how the transfer goes. We know nothing. But what we know is the virus is transmitted, transferred in certain ways. So simply avoid this. You know, that may not be convenient to many people. But if it's simply stupid not to do so, period.
Any thoughts from the other panelists? So of course, if we didn't allow for stupidity, we wouldn't be able to have very much say about the social determinants of health, right? Which is largely based on that.
But you know, if I just may interfere, because in former times, you know, nothing was ideal. But if you had an authority who could decide, it doesn't matter how you call the authority, a dictator or an enlightened dictator or whatever. But at the end, somebody was responsible and somebody was accountable. And I think unless our social structures reintroduce experts and accountability, also political accountability down to the bottom level, we will have a problem in all these aspects.
But, you know, I think one of the things your point does not address, though, is, and I'll come back to this, is poverty. So when we were seeing Zika rampage through the Western Hemisphere, Latin America, now the southern part of the United States, it was clear that women who lived in poverty, one, did not have access to window screens and lived in areas where environmental degradation was, so they could not help but avoid mosquito bites from Aedes aegypti mosquitoes that had Zika. They did not have access to contraception. So I think that's where we need to level the playing field in many respects. Joy, what do you think about that? So someone who's given a lot of thought to women who live in poverty.
Yeah, I think where poverty is an impediment, it's quite obvious that addressing poverty is going to take care of a lot of the challenges that we face and be responsible for modifying behaviors, or if not modifying the behavior, then the interaction between the vector and the human being. But the problem is that poverty eradication or elimination or alleviation is a long-term intervention. And we do need to have some medium-term interventions that are going to interrupt that transmission between the vector and the human being whilst we are addressing poverty eradication. And I think that is where the serious challenge is, and that is where the application of the issues of accountability, not just being accountable for yourself, but be accountable for the livelihoods and well-being of other human beings as well, which is what defines us as a human family.
Thank you very much. Yes, sir.
I fully agree on this, and I think we all agree also education is important. We couldn't agree more. The question, however, is how to implement education and how to implement this in areas of poverty and areas of other unequal issues. I think that we have to think about how to find a solution.
Yeah, I mean, one of the findings of the new book I just put out was that, and I still don't really know all the reasons for it, but it's the poor who live among the wealthy that are hyper susceptible to poverty-related neglected diseases. So it's the pockets of poverty in the 20 wealthiest countries, of the 21 wealthiest countries, that are ultra concentration. So it's not just poverty, but it's inequality. I think that's going to be a very important theme when we talk about global health. The professor's been standing there patiently.
Well,
introduce yourself as well.
I wish I was a professor, but maybe someday. But nevertheless, my name is John Amwesi from Ghana. I'm with the African Research Network for Neglected Tropical Diseases at the Kumasi Center for Research in Tropical Medicine in Ghana. It's interesting you raised the issue of inequality. And one of the things I wanted to talk about during my talk, I didn't have enough time, was the fundamental cause theory and how we have not yet applied that very much to infectious disease. And the fact that, indeed, it's this understanding of fundamental causes that helps us to better address the solutions. And it's no surprise that, as you rightly said, we see these pockets of poverty within highly developed countries. I believe you referred to it as blue marble health, which indeed is the case. But my question substantially had to do with surveillance and the relative absence of focus, or shall I say funding for that matter, for surveillance-related activities. It's very clear from the Ebola crisis that the solution to the problem, the major solution to the problem, what really was a game changer, was surveillance, which was carried out essentially at the community level by people who are members of the community. You can break it down to that. But in all these meetings that we have and other activities we carry out, there seems to be a relative absence of a focus on surveillance. We like talking about early warning systems and all that, but without having substantial surveillance activities within the countries that are most at risk of these, we risk being sprung upon by another epidemic. We don't have any information on Zika transmission within Africa at present during this epidemic, but it would be quite a surprise if there's no active transmission going on. But we don't know because there's no surveillance. So I'd like to have comments from the panelists on that.
It's a great point. We actually have no idea about the United States because Congress never appropriated funds. We've never done active surveillance for Zika in the United States. We won't know if we've had Zika outbreaks all on the Gulf Coast till next spring when microcephalic babies are born and we see where they're born. So,
Mr. Chairman.
Or Professor Kaufman, sir, because I know at Pasteur there's a very active program of surveillance going on.
Yeah, no, but
We'd like to know more.
This comment is obviously very important, and I really agree with the point which has been raised. Surveillance can only be really concretely achieved again if you build with local governments, obviously, with local institutions, with trust. That means that you really need to have long-term actions. And again, you need to have on-site capacities to generate the data. You cannot have surveillance, a real surveillance, if you don't have the capacity to store samples, to analyze samples, and then to share the information. So really, we always go back to the necessity to design in the future large programs conducted in coordination with the governments and the institutions, where we invest in the sharing of information, in the IT infrastructure, in the biological resource infrastructure, and as it has been again and again emphasized, but harder to really concretize, education and training. So I really agree that this is a key point. There is Zika in Africa. We have, for example, the Institut Pasteur in Dakar. They have very good data. They share the data with others, but it is true that we do not have, today, we do not have the overall pictures of exactly what is going on in Africa regarding this disease. And this is just an example.
Thank you for that question. I think surveillance is extremely important, and I think this panel almost completely agrees on the fact that we know very little on Zika, and we are still waiting for knowledge to emerge. Let me share with you, as I said during the course of my talk, based on pregnancy registry records and laboratory testing evidence in the United States, there are 837 confirmed cases in the U.S. and 1,638 cases in U.S. territories, which includes Puerto Rico, which are currently being tracked. So I mentioned this fact this is how fledgling it is, but at least in the cases identified, cross-correlated with laboratory testing, the beginnings and the foundation of what knowledge should be has been put in place.
Fully agree. I think you put your finger into a real wound, and that is public health and surveillance issues are underestimated in the industrialized world. That needs to be strengthened. And again, as Christian said it, I mean, we need a sustainable infrastructure. So I think at all levels of politics, we need to strengthen the activities that are ranging broader and include not only research and development from a bioscientific standpoint, which often includes lab work, but surveillance and other factors of control. And I think really the best way to get that done is to have epidemic centers there, if I may call that word, regional centers, but also have the spread and need some dedicated funding mechanism, whatever it is called ultimately, to establish that at the place, and that is at different sites in Africa.
Thank you very much. Dr.
Just very, very briefly, I agree that surveillance is extremely important and that it has to happen at community level. But one of the challenges that we have, at least in Africa, with our health system is that we haven't fully integrated community health worker, the community health worker cadre, into the health system. And in the cases where we have community health workers, they are very, very poorly trained, and in some cases have got 2 weeks, 3 weeks, 3 months training. And in actual fact, they tend to be more of a waste of resources than a real investment. And I think during the SDG era, this is one area which we really have to invest in properly and prioritize. We can't, not everything in health can be a priority, because everything in every area, when we talk about it, we say we need resources. But the resources that we have, we are not using efficiently. The investments that we are making, whether domestic or international, are not being invested in the right areas or in the right way. And I just want to underscore this and underscore the fact that where we do have community health workers, let us train them properly and train them to do this surveillance work as well, and ensure that we link our resource investments in these laboratories with the work, the results that we want out of the work. I just want to underscore that I'm not saying we have enough money, but what I'm saying is that if we want to be clever human beings, then like the professor says, then we must make the right choices as well.
Thank you. Yes, we have a question.
Hi. Firstly, thank you so much for such a fantastic talk so far. My name's Neil. I'm a medical and PhD student from Melbourne, Australia. And so for some context, I'm currently doing my PhD in mathematical modelling of Ebola. So in the interests of the title from Ebola to Zika, as you mentioned, Honourable Mr. Kumar, Ebola's been around for 40 years. There's been approximately 20 outbreaks. And at the same time of the West African outbreak, there was also one in the Democratic Republic of Congo, I believe about their 7th or 9th, which resulted in approximately 60 cases. So I guess a next question is that if we're going to learn from Ebola and apply it to Zika, how much have we been learning from Ebola and applying to Ebola in the first place? I know personally, from reading the literature on the mathematical side of things, not a great deal of things seem to have changed. There have been some differing approaches, but a lot of models are saying the same things and looking at the same things. And of course, there are some core differences between the West African and non-West African outbreaks of Ebola, but there would have been a large number of similarities too. Has that been used? And is that something that's also going to be used from Zika to Zika as it spreads from country to country, if that happens to happen?
So the question is, how are we taking lessons learned about Ebola and actually changing the way we do business?
This is also a very important question. I believe that there is a reanalysis of the Ebola crisis, which is very informative, and also including mathematical modeling and molecular epidemiology, which is very informative. I believe that the problem is exactly as this has been described. We are lacking, actually, a lot of data regarding the previous epidemics. So actually, a part of the problem we can only guess from some of the reports, because this was so much underappreciated when it was, for example, in the Democratic Republic of Congo. But yes, there is the possibility to reanalyze. So I'm not telling that this is done properly and that this is done enough, but this is exactly what we can achieve. And also, for example, sequencing of the viral strains has been very informative on exactly what has been going on.
Professor Zinkernagel, and then we'll do.
You know, medicine in very general terms has always been empirical. Understanding of the molecular details is like frosting on the cake. So Ebola is a very easy disease. When you go 600 years back or 700 and you look at smallpox in Western Europe in the 1300s, it's exactly what happened now with Ebola. In population-dense environments, 90% of the population die upon a first exposure. Then things change, partially because of the maternal antibodies that then attenuate subsequent generations. So, but a lethal virus is a lethal virus, and it should not kill 100%. It never does. So, and the rest is, you know, whether you are good in modeling or not so good in modeling, is statistics at a very, very simple level. If the population is dense, many get killed, particularly if they think by hugging the dead patient, you know, that helps the dead patient to achieve some goal, then you are on a lost planet. I mean, it doesn't work.
Well, I would just stress one aspect where we really made progress, in my opinion, which is involving estimations and estimates, and that is the development of vaccine trials under difficult situations. That is, often pathogens become non-orphan or relevant pathogens. It all started under the Bush Biodefense Program, as many of you know, what could be never tested. We have learned that we have to go as far as possible in animal studies, and then as soon as an outbreak comes next time, hopefully are ready to do a vaccine trial the right way, respecting humanitarian issues and biomedical issues. And I think there a big progress has been made, at least in my talkings with many people before and after Ebola. There is a change in that area, which I think for so-called easy disease, if I may use Wolf's term, this can be the breakthrough for Ebola. And I think that's an important issue, which involves non-governmental and governmental groupings, local and international as well.
Thank you. Well, we're past time. This has been an amazing panel, as I promised it would be, and I've learned so much, and I look forward to staying in contact and look forward to hearing your thoughts as we move throughout the Congress. The session's concluded. Thank you.